much for tuning in to Grasp MRCOG. My name is MRCOG. I'm a member of the Royal College of Obstetricians and Gynaecologists, and I'm also a fellow and a member of the College of Physicians and Surgeons, Pakistan. I've been working in the NHS for the last few years, and I've been guiding the exam candidates for MRCOG Part 3 for the last few years as well. And through this channel of Grasp MRCOG, I've been making short videos to make things simple for the candidates. If you want to discuss anything, please send me a message. And thank you so much for watching today's video. Hello everyone. In today's short video, we will be discussing the Urogynecology module. Let's see how we can take a perfect urogynecology history followed by reaching a diagnosis, and then we will discuss briefly some common urogynecology scenarios that you will not only encounter in the exams, but that's also important for your day-to-day practice. So let's get started. Okay, so just assume that a patient is referred to you by their GP with some problem with their waterworks or some urinary symptoms. So what you will do is to introduce yourself to the patient. Hello, my name is Amara. I'm one of the doctors in the clinic today. May I please confirm your name and age? That's an important part of patient safety. You should always remember to confirm the age or date of birth along with their name. And after that, either you can say, how may I help you today? Open question is a good way of starting a consultation. Otherwise, what you can do is to tell them, I understand that you have been referred by your GP because you've got some problems with your waterworks. Is that correct? They will say yes. And then you can say that because I'm seeing you for the first time. So is it okay if I ask you a few questions? And then I may need to do some examination and run a few tests so that we reach a diagnosis and make a management plan together. And before you leave from here, I'll give you an information leaflet and also write a letter back to your GP so that they are also in loop. How does it sound? They will say, yeah, perfect, that's fine. Okay, so then you can start taking the history. So urogynecology history, if it's systematic, it can be very simple. If it's not systematic, it can be very chaotic. So you just need to practice a few times to learn taking a good urogynecology history. So either you can again ask an open question. Can you tell me what actually the problem is? So they will tell you a lot of things about their problem. Or otherwise, if they miss some things, then you can ask a few more questions, such as frequency of urination, nocturia, how many times during the day you go to the toilet, how many times during the night you go to the toilet, urgency, do you have to rush to the toilet to pass urine, do you leak at the time of stress, for example, while sneezing or coughing, do you leak when you have to go to the toilet, have you ever noticed any blood in the urine? That's a very important question, so never forget about hematuria. Okay, and do you experience any pain or burning or stinging while passing urine? Or do you experience any pain when your bladder is full? And do you think that the pain gets better when you empty your bladder? So these are some different ways of asking these questions. There is again no right or wrong, just develop your own style. But this is just to simplify and make it very simple for you to understand. And with practice, you can develop your own style and you can ask these questions the way you want. Okay, and then do not forget to ask about any bowel problems and any bulge down below. Okay, so I generally keep in mind that there are 5 B's for urogynecology: bladder, bowel, bulge, bleeding in urine or blood in urine, and boyfriend, that is sexual history, any incontinence at the time of intercourse. So just keep these things in mind so that you do not miss on any of these, because these are important symptoms which are related to her urinary problem. So in urogynecology, we do not have to just focus on the urinary problem, but we also have to ask about the other 3 like the other 2 compartments. Okay, so ask about the uterus, the prolapse, and ask about the rectum, the bowel. Okay, so coming on to the next part, the rest of the history. For the women who are in reproductive age, you can ask the general history like the menstrual history. If she is postmenopausal, ask about postmenopausal symptoms. For younger women, ask about her obstetric history. mode of deliveries, any difficult deliveries, and her fertility wishes as well, because fertility wishes are very important in younger women. Sometimes women with urinary symptoms may still would be planning a pregnancy, they may still would like to conceive, so that's also important to establish that what are their fertility wishes, because that can have impact on their management. And whenever you ask about the sexual history, always give them a warning. That is, I will be asking you a few personal questions regarding your sex life. Is that okay? Because it might be helpful for me in management. Okay, so then they will say yes. So just wait for them to respond to your question and then ask about the sexual history. Then again the usual history, cervical smears, and then the general history, like how are you generally fit and well, do you see your GP regularly for anything, do you use any regular medication, because women who are using some medicines like diuretics that may increase their urinary frequency, or some many other medicines that can have impact on their bowel movement, so these things are also important. So that's why always ask about any regular medication, any surgeries in the past, any surgery on your tummy or down below. Okay, and then smoking, alcohol, and drug use, then the social support, partner support. And in urogynecology module especially, and generally in any scenario, always establish what impact is this problem having on the woman's life, on her quality of life, on her day-to-day life and her relationship. And when she tells you about this, then always express empathy, stop there and respond to her expression of her problem. For example, if she says, yes, I'm extremely upset because of my problem, I really want a solution, so you can say, I'm really sorry that you are going through this, or I totally understand that you are going through this, but we are here to help you. Okay, so we will try our best to reach a management plan so that you feel some improvement in your symptoms. Okay, so always respond to the clues that they give you. Okay, partner support is also important, because if there is an impact on the quality of relationships, then sometimes there can be an element of abuse in the relationship. So that's why it's important to rule out domestic violence. But in any scenario, you have to rule out domestic violence in any case. Okay. And then you can mention about examination. In online exam, you won't be obviously examining the patient, and even in face-to-face exam, you're not expected to examine the patient, but you can mention that at some stage, I would like to have a feel of your tummy, do a vaginal examination to check the tone of your muscles, and a speculum examination to see if there is any leak of urine, so that the examiner knows what is your thought process. And then you tell her about investigations. Because if she is referred by her GP, it's quite possible that she already had some investigations. So ask about those investigations, and also ask about what she has already tried for her urinary problems. For example, if a woman has come with stress incontinence, I mean, based on history, you think that it's stress incontinence, then she may have had bladder diary given by the GP, or she may have been advised to do pelvic floor muscle exercises, because you are sitting in tertiary or secondary care, and in primary care the GPs will have done these things, and after this initial management is unsuccessful, then they refer the patients to you. So always establish what kind of treatment she has already tried, and also ask about any other treatments, like any even complementary therapies, any other kind of treatments, any herbal therapies. So sometimes these for any kind of problem, people do try different therapies. So it's always important to establish what they have tried before, because sometimes these kind of therapies can also have interactions with the medicines that we will prescribe them. Okay, so when talking about the bladder diary, coming to the investigations, talking about the bladder diary, you will tell her that it is a record of the bladder habits or the drinking habits, and about your urinary frequency and leaking. There is a record and you maintain it for at least 3 days, and on which you mark how much fluid you drink, what type of fluid you drink, how often you need to go to the toilet to pass urine, what is the amount of urine, and how many episodes of incontinence do you have along with that. Okay, so this is something she might have done already. Otherwise, if she hasn't done, then you can offer her bladder diary. Then comes the urinary and urine analysis. It can be done in the clinic very easily. So you can tell them that we can test your urine now, and if there is any evidence of infection or she's symptomatic of UTI, you can also mention that we will send your urine to the lab to test for any bacterial infection. Okay, because that can also be a cause of her symptoms. And sometimes women who have got an overflow incontinence, bladder scan might be helpful. Okay, and urodynamic testing might be helpful in cases where the diagnosis is not a straightforward stress incontinence, but there is something else such as overactive bladder or mixed incontinence. Okay, or a woman already had some surgery and she has come again with some urinary symptoms. Okay, and you can explain a little bit more about the urodynamics, but always ask about before telling a lot of detail about any examination or any investigation or any diagnosis. Ask the patient, do you want to know more? Because she is the one who should be guiding the consultation. It shouldn't be a one-way communication, and every 1 to 2 minutes just keep on asking her, am I making sense? Do you understand everything? And do you want me to repeat something? Do you have any questions? Anything that you would like to say? Develop your own style again. So just keep on asking them for their understanding, and also make sure that she is with you. It's not only you who is just regurgitating their knowledge. Okay, so it should be the patient leading the conversation. Okay, so in terms of the diagnosis, the two most common diagnoses could be an overactive bladder or a stress incontinence. So how would you explain stress incontinence? So you can either, in case of a face-to-face exam, you can draw a diagram and you can tell her that this is your bladder and this is a water pipe which takes the urine out of the bladder to the outside. Okay, and this is your these are the muscles which support the water pipe, and they help in the control of passage of urine. So they keep the water pipe closed when you are not going to the toilet, when you are not in the toilet to empty your bladder. So when this muscle support becomes weak, so whenever you put some pressure on the bladder, for example, when you are coughing, when you are sneezing, doing some exercise, running, or sometimes at the time of intercourse, then what happens is that a little bit of urine just keeps on leaking because of this weakness in the muscle support. Now we have to work on that. So just let's first discuss the stress incontinence so that you can tell them that how we can work on that. So in terms of management, you can tell that we've got 3 types of management: simple Meyers, surgical Meyers, and medicines. Okay, and then tell each and every one of these one by one. So you can tell that in order to strengthen this muscle support, what we can do is to, let's start with some basic Meyers, some dietary modification, some modification in her fluid intake, and along with that weight loss if the BMI is on the higher side, and then comes the pelvic floor muscle training. If she has already tried the pelvic floor muscle training for some a little bit of time, then you can tell her that that you can just continue doing pelvic floor muscle training for like 3 months or so, okay, so that it shows its effects. I can also refer you to the physiotherapy and stuff like that, okay. And then comes the surgical Meyers for the management of stress incontinence. So you tell her that there are certain surgeries that can be helpful in strengthening of this support of the water pipe. So we can do some stitching around the bladder neck to give strength to this to the muscles around the bladder neck. Okay. So or sometimes we can do some injections inside to increase the bulk or increase the thickness of the a water pipe. Okay, and also you can tell about the sling operations. If they ask about the TVT, because sometimes in exam scenario, because TVT is now obsolete, so just to check their knowledge, they might ask you about TVT. For example, they may say, one of my friends had a tape procedure, so that was very successful and she's perfectly fine. Can I have that? Then you can tell her that this is something that we used to do, but because of the risks of the procedure, it has been obsolete. So we are not offering it to the women at present. Okay, so this is just a simple example that how you can deal with a case of stress incontinence. And then you can also talk about certain medicines, because the third form of management, which is not the first line in this situation, that's the second line. So you can talk about duloxetine and a little bit about the side effects of duloxetine, and tell her that this is an antidepressant and what are the side effects. You can generally tell her about these things. Okay, and if the diagnosis is overactive bladder, then what would you do? Then you can explain the diagnosis of overactive bladder, that this is your bladder and this is the water pipe, and this is the muscle support. Now the problem is not with the water pipe, the problem is not with the muscle support. So you explain it to her that there is a problem in the muscle of the bladder, it is more sensitive. Okay, so there are certain things that you can do to reduce this sensitivity. For example, lifestyle changes such as losing weight, eating healthy diet, and doing some exercise. Cut down on your intake of caffeine and alcohol and fizzy drinks. Okay, because these can be irritants to the bladder. And also drink between 1.5 to 2 liters, as drinking too much or too little can make incontinence or these overactive bladder symptoms worse. And also plan toilet breaks. Okay, bladder training or plan toilet breaks, they can be also helpful. For example, techniques to increase the length of time between feeling the need to pass urine and the course lasts for at least 6 weeks, and specialist nurses can teach you how to do that. And then tell her about the second line management for overactive bladder, such as the anticholinergic medicines. And then you can tell her about different tell her the names of different medicines, but that's not very important. But you just tell her about the symptoms of those medicines or the side effects of those medicines, that are such as the dry mouth, constipation, blurred vision, flushing of skin. And also tell her that if she experiences these symptoms, then it's a sign that the medicine will start working, but it will take up to 4 weeks to see the effect of the medicine, and then she will be called for follow-up for after 4 weeks. Okay, and then you can later on tell her about certain other mayas, such as the if the medical management has failed or it is not effective, then she can have urodynamic testing, and then it will be also discussed in an MDT meeting, which is a group of experts, okay, who can decide which surgery is suitable for her. For example, Botox injections. Okay, and then you can also tell her about the side effects of the Botox injections, which are these are the injections in the wall of your bladder, and sometimes women can find a difficulty in emptying their bladder, and sometimes they may have to empty their bladder using a thin tube, which is called the catheter, and which we will teach you. And this may they may also need to have repeat injections, and then again the response can be assessed after 12 weeks. Okay, and then the other options next to that, either the percutaneous sacral nerve stimulation, and it could be done either if the patient refuses or the Botox injections are not suitable. Okay, so these are the things that you can do for the overactive bladder, and this is how you can explain overactive bladder to them. So tell them about the rest of the treatment if they are interested in, because at that stage when they just present to you for the first time in the clinic for consultation, you are not going to tell them about all the options, including augmentation cystoplasty, but because you also have to tell the examiner that you know everything, but again, asking the patient about every management option before telling her a lot of details. Do you want to know more about that? Everything about their symptoms, then it will be very easy for you to go ahead with the consultation, because in that case you will not have to ask a lot of questions yourself. If they have missed something, just add on later on, okay? And always ask about those specific points, that is frequency, urgency, nocturia, hematuria, and the 5 B's that I have mentioned in the Urogynae history. So that will streamline your history, and the rest of the history is the same. And then there are certain important scenarios that you can expect in exam and also in your day-to-day life, such as stress incontinence, mixed incontinence, overactive bladder, and bladder pain syndrome, in addition to the prolapse related scenarios. So if you master the history taking, that will be very easy for you. You will be able to identify which problem is that, and based on that problem, then you can take it from there. And then, because all of these issues have got a totally different management option, you always tell them about conservative medical and surgical management options, but the sequence can be different based on the diagnosis. And I hope it is helpful for you. If you want anything else that we should discuss on this forum, then please send me a message. I will be very happy to share any other videos with you. Thank you very much for listening.